I was using this one.
Good morning, everybody. Mackenzie just sent around the recommendations too, just in case you didn't see them. Are we waiting for Allie or should we get started? Okay, it's on YouTube. Great. Good morning, everyone. Welcome to the Insurance and Real Estate Committee's working group to study pharmacist compensation. Today is Wednesday, December 3rd, 2025. And I just want to thank everyone for spending time with us over the summer, fall, and now winter to work on this and to educate everybody and have this really interesting discussion. I have learned a lot. I have learned that the role of the pharmacist is very complex, but very important to the health of the patient. I've also learned that sometimes the pharmacist know more about a patient's health than their actual primary care physician, which I think leads us down a path of doing a lot more work in this space because, we want to make sure that everybody has the full comprehensive overview of somebody's health. It's really nice to hear that that pharmacists play this very important role, but I think it just shows the gaps in our overall healthcare system that do exist that we can do better at. So thank you again for participating. I want to move to the presentations and recommendations section on the agenda. And we will keep this very open regarding dialogue. Everyone that's online, please feel free to raise your hands and ask questions. But we were presented with two recommendations, and I will ask if anyone, Dr. Sam, if you would like to, I don't know who these came from, but we have recommendation 1 and recommendation 2. If anyone would like to take the lead, whoever presented these, and just going through them for the committee, that would be great. Anyone interested? Great, thank you.
Good morning. Thank you so much. I think you'll see from our presentation that the two proposals very close. The meat of in languages in both documents are exactly the same. I'll start first by saying what is not in this proposal. First, neither one of this proposal add any services that are not included and covered today. We're not asking or recommending to add services that are not covered by insurance today. 2, we are not requiring payers to change the way they approach contracting, credentialing, or any other processes that they have placed for any other provider. So they still have all the leverage, the ability to maintain what they do today in terms of require specific rates, specific contracts, credentialing process. The proposal number 1 is based on the language that was approved at least in 12 states. And it essentially says that is any service covered today by payer and reimbursed for a variety of healthcare providers. Could be physicians, APPs, which could be a PA or EPRN. And if this service can be provided by a pharmacist under their license. So and we talked in the past about scope of practice or license. This is something they are licensed to do under 400J. What we're asking is that pharmacy should be treated exactly the same way the other healthcare providers are being treated. So the service provided by the pharmacist under the license should be covered in a similar manner. Not mandating adding services and not mandating a specific rate, simply equity with other healthcare providers for the same service that they are able to provide today. You can see that we listed some of the other healthcare providers. I just want to also highlight the last bullet that this is not requiring insurance or any healthcare plan provider or third-party administrator to reimburse pharmacists or making them a preferred provider. It's really parity and equity with other healthcare providers in the state.
Okay, great. If we have any questions, please raise your hand. I do have a question that I was wondering if you can answer. So would this add a cost? Would this add on to the total cost of, say, a patient goes to the doctor, gets prescribed something. They go to the pharmacist to pick it up. Is this adding a cost?
It should not add cost to the prescription that being dispensed. This is essentially if you're going to get a specific service from today, you get that from a physician or APP. The same service could be provided by a pharmacist, just like a vaccination. Right now, you can get.
So it's in lieu of.
It will have to be. It's really the same service. It is.
Got it.
In exchange of going to one of the providers. And I think we talked about that in the past over the last few meetings, that it's access. Right now,
Yep.
You could get vaccine, but you cannot get it from your doctor. You can now you see your pharmacist and get that vaccine service, among other things.
Yeah, and then I have a question for Troy. Do the pharmacists need anything additional by the Department of Consumer Protection or the Department of Public Health in order for this proposal number 1 to be implemented?
I just got a chance to look at it today. From looking at it from an overview, I really don't see any addition for us or any changes that we would have to necessarily do to allow them to do this. They're currently providing vaccinations now. So it would just be the reimbursement piece would be the focus I think that we're here for.
Any other questions or comments regarding proposal 1? Sue Halpin?
Good morning, everyone, and thank you for the conversation that I think we've had here during this task force. I think it's been really informative for me and for the broader audience that's been listening. I was going to reserve my comments until we walked through both proposals. And we're still reviewing, to be fair. I do see proposal 1 as more of a mandate in the language that starts with may not deny reimbursement. So again, I was going to kind of wait for additional, for the opportunity to make comment until we walked through both proposals, because I see proposal number 2 is being more something along the lines that we could work with going forward. But I do have concerns about the language in proposal number 1.
Sue, can I ask you to elaborate on the may not deny and how you envision that as a mandate?
Sure. It basically says that, I'm just trying to read the section E. This section may not be construed to require an insurer or other health plan to reimburse a pharmacist or other pharmacy as an in-network or network provider. But it doesn't talk about lots of the other provisions, I think, that would go into a network. And it basically says, when you say may not deny reimbursement, to me, that is a mandate for services, as opposed to when you look at proposal number 2, where it says that can't be denied solely on the basis of the provider's licensed type, and that reimbursement processes and provider networks are inclusive of licensed pharmacists for the purpose of reimbursing covered clinical services. I think one is much more mandate oriented than the other. And I can get you more detail on that as we've had a chance to digest this a little bit more.
Why don't we move then to proposal number 2, and then we can go through questions on both and compare each.
So as I mean, considering proposal number 2 is similar in the aspect of just providing a pathway for us to be able to get reimbursed for services. There's still going to be contracting requirement with each individual plan, and the licensing piece would fall under the 400J as it stands today. This language does mirror similar languages to what was passed in Texas and Washington, which are some of the more progressive states. However, it avoids the mandate that I think we're all worried about. As far as the cost portion that was brought up as a concern too, it's a pathway for the patient to get care faster and then still be able to reduce the overall cost by them being treated sooner than later. Instead of waiting 3 to 6 months to see a provider, we're shifting that earlier in the healthcare journey and then hopefully capturing and reducing the overall burden on the healthcare system. Because as I see patients with limited access to primary care and being able to get their diagnosis done, it leads to urgent care and or they end up in the ER. And I think from a burden from the healthcare system, it also will alleviate and provide a different pathway for patients. But I think the key piece to this, it's still contract-based with each individual plan and each individual provider. So that way we're able to establish that pathway to reimbursement.
Questions or comments?
I would love to comment or just reply to Susan's concern. I'm going to say in my lane, which is a pharmacist. I'm not an attorney or expert on the language in the law. So if the language in the proposal number 2 that says shall not deny reimbursement solely based on provider is more reasonable, I actually have no problem with either one. To me, they sound the same. Again, as a pharmacist, what I'm hoping to get out of this work that we've been doing for multiple meetings is have actionable piece of legislation or a law, anything that is so generic that does not have any action behind it, that really gets us nowhere. That's where there's a problem. So as long as there is a clear plan after that goes through, whatever the language is, I'm fine with either one.
Sue?
Can I just ask a clarifying question, if I might? Is it proposal 1 or proposal 2 that mirrors Texas and Washington? I thought it was proposal 1, but maybe I'm incorrect.
I'm almost certain the proposal 1 that says may not deny reimbursement is the commonly used language. That proposal 2 is actually what would be softer than what's approved elsewhere. I actually think they sound the same, but again, that's my inexperienced eyes. May not deny.
So let's talk about implementation of something like this. If we can all just kind of talk through this so I can better understand. Considering what we do in the state and what we regulate, how would it work regarding the ACA plans versus commercial versus Medicaid at the point of service? And maybe you can walk through what some others, clearly other states have done this, so it's not like we're reinventing the wheel, but do you know how that works?
So Representative Wood, maybe I can just ask you to clarify. When you say implementation, do you mean on the part of the payer, the provider, all the above?
Yeah, kind of all of the above,
Yeah.
because we're basically what we're doing here today is affecting 150,000 people. So, does this make the already complicated system more complicated? Are we going to lose people? Are we going to confuse people? Or is this a seamless transition? And again, just your thoughts on your discussions with other states.
So University of Connecticut, where I'm at, and Medical College of Virginia back in March had a national conference on, it was specifically Medicaid payments. So it was focused just on Medicaid. And we had representatives from all 50 states, and some had both commercial and Medicaid coverage, some had just one or the other. And I think the kind of one of the key messages that came out of that is a good point you're making, is just passing language in a bill does not at all address implementation. However, there needs to be enough action plan, as Sam's saying, to make sure you've covered implementation issues. So for instance, I'll just take Virginia. Virginia said, we thought we had this beautiful bill and it covered just about any circumstance, but Medicaid didn't know how to go about and credential pharmacists, or even commercial sometimes didn't know how to credential. There are, I think, two things that need to be in place to implement. One is you have to have the network that says who are the people who are eligible to be even involved as providers, as pharmacists. So credentialing is important. The one thing I think that many states got a lot of, they just delayed everything, was that they were trying to come up with specific implementation recommendations for credentialing pharmacists. And other states said, it's really for the same as you would for any other healthcare provider. So there's nothing unique about credentialing pharmacists. There are organizations that do it specifically for pharmacists. There are those that do it for commercial health plans. And so they have now added on, requirements and processes for pharmacists to be credentialed. So first there needs to be that credentialing piece. Some payers were interested in knowing, well, do we need to have specific codes that are only allowed for pharmacists? And I think that's a whole other discussion outside of this, right? But those are some of those implementation issues are the really critical discussions that have to happen outside of this process that will make it be smooth or kind of muddy.
So I see this July 1st, 2026 effective date. Maybe that's a January 1, 2027 effective date. Just some thoughts to that, considering working through some of those things. Not like, we're trying to kick the can down the road. It's just that we're thinking through all of this. So that would be one recommendation. And I do see Kara, Representative Pavlak-Tomato's hand up, so I will go to Kara. Representative Pavlak-Tomato.
And just, I know I think the gentleman before had mentioned about not denying reimbursement, but I thought both of those have that language. Proposal 1 and 2 have the shall not deny reimbursement language. So I'm not sure which one he was talking about or how they're different in that regard. And also we had talked about before Texas, and I had pulled the bill that was the number that was given to us, but that bill, and that was, I think, at our July meeting, but that bill actually had to do with vaccine mandate, vaccine like harm liability. So I didn't find that to be related to what we're talking about, and I wasn't sure if there was another Texas bill that we could research.
So why don't we start with the first question that she had? There is shall not deny reimbursement language in both of these. Does anyone want to comment on that?
I have a comment, if I might.
Sure, Representative Meskers.
So I think the words of shall not, we're trying to address an issue which is for improved health care. And the concern is whether or not they can be denied. And I'm wondering if the caveat it's they shall not be denied without cause, without reason. I mean, if we're trying to figure out where we go with this and providing access and improving healthcare outcomes, shouldn't we maybe at some level increase the responsibility? I'm open to listen to the insurance companies about without cause or reason. But if they shall not deny and then they believe there is a rational reason, I'm not sure that we're just saying you have to supply that. So I'm a little bit concerned that at some level it's a mandate, and at some level you are moving the insurance company out of any role in the allocation. And granted, you know, we've been in a very tough time reputationally with insurance companies in denial of coverage, but maybe what we want is an explanation of the denial so that we can deal with it from that issue going forward. If there are denials and we're beginning to see a problem arise from those denials, we address that in further legislation versus today. That's just my thought on it.
That's absolutely reasonable. Any other qualifying language to explain when service can be denied, that's perfectly fine.
Because the heart of the question is denial of service, or the supposition of a denial of service that isn't justified. And so I don't want to just make it a mandate that doesn't qualify it. That's my concern.
Absolutely. And the heart of the issue from my perspective is adding pharmacists as providers. Yeah. When is it covered? What the qualification for that? What is the process? That all is really something that we have to work through. It's adding the pharmacists to that list of providers. That's
right. And if I might, where the argument will arise between the physician groups and pharmacy groups, in my mind, is the hamstringing of the insurance companies, because, you know, we've had this conversation about podiatrists and treatment as well. And one of the issues where I think we're always striving on the insurance committee is to provide better coverage at a lower cost. So I'm trying to figure out is, you know, how we qualify service, how we qualify the types of service, how we qualify reimbursement. I'm not trying to drive pharmacy companies into a problem. And at the same time, if they are providing services, I want them to be judged the appropriate way, because we're trying to both impact cost and impact coverage. So I want to make sure we're thinking about both of those lines. It's a comment I made in the past, not always well received, and I understand the concern, but I am worried about cost as well as coverage.
Thank you, Representative Meskers. Representative Nuccio.
Thank you. So I'm looking at the language in the PDF here, and I'm assuming that none of this takes place without pharmacists going in front of, I believe it's public health, to even classify them as something that they're not classified as now, which it looks like clinician. Is that what it is? Is that correct?
So in terms of the qualification, there's providers such as Acorn, for example, that does go through the credentialing portion, and then based on the training and additional requirements under the Department of Consumer Protection, each of the pharmacists that go through all of the requirements would be able to provide the services based on the contract established with that specific plan. So we can pick plan ABC that covers company Y, and they want to say that pharmacists can reimburse or can bill for a clinical service that they're authorized to do under 400J, then they would use the provider coding to be reimbursed for that, given that they provide the documentation needed, they provide the service, and are contracted to do so based on their education and training they've received. So I think there's a couple of things there that would have to happen, and I think that's the pathway that will have to get established in order to even pursue this reimbursement journey that we're headed on. And I think from the January 1st standpoint, I think that's fine because it gives time for the insurance companies to establish the plans and incorporate us into their plans. And then based on the contracting that goes on throughout the summer into the fall, I think there's a lot of time there where those can land in or be placed in each of the contracts.
So I don't think this is something that insurance companies would incorporate into their plans, right? Looking at what you have here, it's basically making sure you expand your scope to be able to provide services, which I'm assuming are just administration of vaccines and such. You're not going to be providing physician services. So I think we're kind of putting, it's a good conversation to have, but I don't think we should do anything until we make sure that the scope of pharmacists have been updated to include the services that you guys feel like you'll be able to provide, and that the scope has been assured and we've got everything in place to make sure you're licensed and credentialed correctly before, like, you have to do all of that before we get to the point of saying an insurance company can or cannot deny. And as with what Representative Mesker says, I'm a little concerned about the cannot deny at all, right? Because there are plenty of reasons why claims can get denied, not billed correctly, upcoded. There's, I would never say that for any group, any kind of physician, that an insurance company cannot deny. I think what Representative Mesker said without explanation, yes, absolutely. But to just say outright cannot deny, I find concerning. So Carrie, if I'm hearing this correctly, I think the first step is really the pharmacists have to make sure that their scope includes what it is they want to offer for services. Once that happens, then it just becomes a negotiation for payment from the insurance companies, which we would have nothing to do with, right? They would go through their regular their network contract negotiations to get a networked contracted rate of payment for the services that they're providing. Am I missing something?
Yeah, thank you so much for your comments, and I just want to offer a couple of clarifications. First, we are not asking for expansion of the scope of practice. Everything that we are saying we will provide, we already authorized to do so by law. From vaccination, HIV testing, treatment for HIV, and so and that's why we put under the scope of license under 400J. So I just want to make that clear one more time. We are not asking for expansion of scope of practice. We already authorized to do all those. And actually under collaborative practice agreement within a hospital setting, I can do these things and a lot more today legally. The second issue in terms of the mechanics, before we go to negotiation with payers on what the details of the contracts, under 400J, we are considered clinicians and providers. But that's the only place where our designation lives, under the DCP and 400J. In the insurance world, we are not considered providers and clinicians. And that's what we're trying to do, take the same definition that we have today in one law and apply it to another setting. Hopefully that.
Yeah, I think though, but I don't think that falls under insurance, right? I don't think that falls under our committee. I think that would fall, if I'm not mistaken, and Carrie, please correct me if I'm wrong, under public health, the designation, right? Because I don't think that insurance would be the one to designate you as a clinician.
Well, thank you for that comment. We did ask the Department of Public Health to be engaged, and they basically told Troy to come from DCP and deal directly with him. So So that's why we are here. We did ask that question, Representative Nuccio, in a previous meeting and did try to engage them, but we were told DCP is the presiding agency.
So then would we need to go to DCP to have them update it? Because again, I don't think, do we define this in insurance code anywhere for other types of providers? I don't think that we do, but there's a lot of code, so I could have missed something, but do we have legal research that shows that this is where we should designate that and not DCP? I just think we're outside of our lane a little bit here.
So, Representative Nuccio, I appreciate the comments. Just to let you know, the legislatures have already approved to allow pharmacists to provide services and vaccinations, birth control, PrEP and PEP testing, and other items like that as well. So they are already approved to actually do the vaccinations.
Okay, so if that's the case, then is all you're asking for is the guarantee that an insurance company can't deny you payment?
So we currently don't have a pathway to even bill for those services to an insurance provider.
But wouldn't that be negotiation with the insurance company? If you are a designated clinician and provider, then part of your networking contract would be to establish what CPT codes you're using, what your reimbursement rate is based off of those codes. Like, isn't that the path that you would need to go down?
Correct. And that's what this whole legislation will give us the ability to do so, because currently we do not fall as providers anywhere else outside of the DCP language, the 400J. This will provide a bridge for us to get there. So I think that's what we've kind of gone around in a circle and talked about.
So I think that, not to interrupt you, but I think that's where I'm confused. If we're saying DCP already has you guys classified this way, right? And you're saying the insurance companies aren't recognizing that, I guess that's where I'm lost on this here. Because if DCP already has you classified as a clinician and in public health you're considered a clinician, then you're saying the insurance company doesn't recognize that? Is that what we're...
So we are not under the Department of Public Health. That's the issue.
Yeah, I still am not following. So Representative Wood, maybe we can catch up offline on that, because I'm not quite sure what exactly we're being asked to do here other than mandate that an insurance company has to pay pharmacists. And I don't like the language of can't refuse. That's definitely a hardcore mandate. So I guess I'm just not really following what we're trying to do here.
Thank you. We've had a lot of similar discussions in previous meetings, and we are trying to just find a path forward based on statute, based on oversight of pharmacists, based on pharmacists doing this work, based on their expanded role in the healthcare space. So I think what I'm hearing is that a lot of people are leaning towards Proposal 2 with changes, with softer language, even though Proposal 2 is the softer language, maybe working on that language a little bit more, moving the implementation date out. But we're just trying to find a path forward, Representative Nuccio, and we hear you on all these questions. We've had a lot of these, same questions asked, but we're trying to do the best we can in the space that we're in. Representative Meskers and then Sue Halpin.
Without trying to totally reshuffle the deck, what I'm hearing is the two things. One, and I agree with the chair on the concern about a mandate. The second piece is that it falls under the purview of DCP and not the Department of Public Health.
That's
okay, and I don't want to open that can of worms and derail our meeting today, but I have a question as to, is that the logical setup in our review of the process? I'm not looking to throw away some of our responsibilities since consumer protection falls under us. But if it's a scope of practice, I go back, whichever committee I sit on, and I want a competitive market scope of practice. I want licensing, acknowledgement, and at some level, increased competition. I haven't heard anyone championing that issue, or I mean, we have as a committee that we need more competition, less competition. I want to see pharmacies involved in the mix as healthcare providers. And the question is, who's the most efficient, competent healthcare provider? And that's subject to negotiation. And now we're talking about DCP versus public health. It's a little confusing to me on how we wrestle that issue.
Sue?
I think part of the concern, and maybe it's a question for LCO at some point, is that healthcare professional or health provider is defined purposely differently under different sections of the insurance statute. There are sections that say, or as otherwise appropriately licensed to provide services. So, I think that all of the concerns being raised are very valid concerns. I think it's why, when someone asks what's the difference between, proposal number 1 and proposal number 2, is one is very definitive, as in may not, deny. It's a negative, as opposed to a positive under, proposal number 2, which talks about shall ensure, processes. And I think that's a very different kind of statutory requirement. Again, I can't say here today that I support proposal number 2, but I think what the conversation has been thus far draws the distinction between the two proposals. There's also lots of other provisions that are included in proposal number 2 that talks about, require of coverage and any service not otherwise covered by the plan. It wouldn't be construed to require those types of coverage, or from, establishing reasonable participation in credentialing. I think some of this also really, I think, Madam Chair, your question was the right question early on, which is the implementation of this. You can say it and then you can implement it. And I think one of our good folks around the table talked about, are there appropriate codes for pharmacists to actually bill services that identify to a pharmacist as opposed to a APRN or other type of physician. So I don't think it is without challenge. And I think that's why if we do proceeding along the lines of, processes going forward, you flagged what I really originally wanted to say, which was making sure that we have an effective date that is at least a year out, because there's a lot of changes happening right now, as everyone's followed around under the ACA. And a lot of that is going to require, programming and changes for people understanding their benefit packages. And, a large segment of this market that is covered as a fully insured plan is, under the exchange. Those run on an annual basis. Plans are putting together their benefit packages today for submission in April for approval in the rate setting process. So, perhaps even a 2-year window might make sense in terms of, an implementation timeline, something that we may want to discuss if you decide to go forward with this legislation. And I think one of our good colleagues around the table also raised the prospect of Medicaid. And if, what's good for the commercial market, is it good for the Medicaid market, which is, almost a third of the state's population. So when we're looking at mandates or processes and procedures that are put in place for the commercial market, one of the first questions my carriers always ask is, is that required of the Medicaid system? Will it be required of the state employee system, which is a self-insured plan? So, I think implementation, your question was right on the mark when you first came in, which is you can pass a policy, but what does it look like when you implement it?
So I've also heard in this discussion some great ideas, to do over the next month or so, which is to run this by Access Health. First, I think we should have LCO kind of scrub the language and make sure everything can be implemented in statute and we're not forgetting something. having the Human Services Committee, passing this on to them as well, and discuss with the Comptroller's Office regarding the state employee plan. So these are all great things that we can do before the start of session, which I can take the lead on. Any other suggestions or comments? Maria.
Just one point of clarification about Medicaid. There are several states that, there's probably 30 states, I would say, that do require Medicaid coverage for pharmacist services. The one thing to remember about Medicaid is they don't need legislative action to make it happen. They can do this through state plan amendment waivers, and it can happen within 6 months of what other states are telling us. So they don't require it. There's another process for that. Or there could be, I should say, another process.
Representative Meskers.
At the risk of being repetitive, and maybe it's a larger can of worms, it's the issue of the scope of practice, and given the coding, as co-chair of commerce, the cost of insurance, regulated markets, fully insured markets, improving the competitive landscape and putting pharmacists in a role in the healthcare system, if they're willing to provide at some level competitive or a reduced price. And maybe no one likes to hear this, but I'm thinking that if we're trying to really reform the process as well, it's to give them a role in the system where the system faces competitive pressures, because all I see is, healthcare systems growing larger, acquiring more companies and raising prices. So I'm not adverse to what the mission of the pharmacists and the way they deliver service. So there's no criticism. What I'm trying to figure out is how do I get to a more competitive market as well? So I heard what the mission was here, and I heard what they're trying to do, and I fully support the acknowledgement of the role, the important role pharmacists play in the system. But I don't need to hear it from the insurance companies, and I'll direct it in their direction, or from other people, how we're going to make that system competitive as well on a price basis on delivery of service. And maybe that's further than we're either empowered to go, but I just wanted to register that.
No, that's a really good point, Representative Meskers. And I think even the most important point here is the role that the pharmacists play in strengthening access, which is what I think all of our goal here is, and what I have learned, through the many months of us, working on this topic is, making sure those barriers to access, the wait times and all that stuff are reduced, and there's more options, for patients. And in many cases, we've heard a more comprehensive review of a patient's healthcare records. I don't think anyone in the system that has all of the records in their hand like the pharmacists do. And at the end of the day, they can be prescribed things, and the pharmacist has a say in, hey, this doesn't work with your care, because of X, Y, and Z. So, I think had a wonderful few months of discussion. I think we raised some points. We are focused on a proposal here, or a path forward with some work. Any other questions or comments? Great. Well, I want to thank everyone for their time. I know you could have been doing lots of other fun things during the summer, fall, and winter, but appreciate it. This is hard work but necessary work, and everyone's comments were just really valuable to moving this topic forward. Thank you, everyone.
Thank you.
Thank you.
Thank you.